Smriti ma'am, are you able to hear us, ma'am? Good evening, ma'am. Swagata, ma'am.
Yes, sir.
Good evening, madam. Thank you for joining us this evening.
Good evening, sir.
We have Professor Gaurav Agarwal from SCPG also joining. Good evening, sir.
Good evening.
Thank you, sir. Thank you for joining us, sir.
It's a
Hi,
pleasure.
Gaurav.
Hello, sir.
Yeah, how are you?
I'm good. Thank you. How are you, sir?
Yeah, I'm fine. But
And
situation
sir,
is
Gaurav sir is your student, sir.
yes, that's right. Yeah, that's right.
1992 batch of BHU Varanasi.
Yes,
student.
yes, yes, yes. Dr. Kanayaval, congratulations for the anniversary show.
Thank you, sir. Thank you so much, sir. All of our joint efforts. I'm really proud moment for all of us, rather. It's a teamwork.
Congratulations, sir. First year, first anniversary.
I think we have Professor Jayalal sir also joining us. I think we are now live on air. Sir Jayalal sir, good evening. Thank you for joining us, sir.
Good evening, sir. Good evening.
Kanyakumari or Assam, sir?
Delhi, sir. Delhi.
Kanyakumari or Assam?
Delhi. Headquarters office. We need the night to.
One moment, sir. Let me start out this. So I think PG clinics are now attended by children also, I think. Happy. Sir, we are already 8 o'clock. With the permission of the faculty here, I'm happy to open this anniversary meeting of PG clinics. In fact, with the permission of the faculty, I will show a single slide. Second. So this is the invitation. First of all, on behalf of the academic committee here, we have the committee members already. Dr. Kanna, Shanai sir will be joining shortly. Raji sir is with us. Jailal sir is with us. Srinivasan sir is with us. Karnakaran sir with us. And we have many senior faculty now coming into the committee by regularly attending classes. Welcome to all of them. And I am proud to say we have three eminent faculties for this evening. We have Professor Gaurav Agarwal, Professor of Breast and Endocrine Surgery at the SCPGI Lucknow. Welcome, sir. Thank you for joining us this evening. And he is an alumnus of BHU Varanasi. And he has a very excellent career spanning almost all continents of training. And he was instrumental in setting up the breast services in the SGPGA as early as 1997. And from then on, no looking back, they have the minimally invasive thyroidectomy also in very big numbers. Welcome, sir.
Thank you.
And we have Professor Smriti ma'am. Smriti ma'am is the professor and head of the Department of General Surgery at the HPTMC Mumbai and the R.N. Cooper Hospital Mumbai. Welcome, Smriti ma'am. Thank you for joining us this evening. And we have Professor Swagata. Professor Swagata is the professor of surgery at the All India Institute, Bhopal. So thank you all the invited faculty.
Yes,
Before we start, I will quickly give the glimpses of the data which we have accumulated over the last 1 year. We have students from 26 countries attending to our classes at various times. We so far have completed 74 classes for the whole of the last 365 days, of which the early part we had 2 classes per week. Now we have shifted to 1 per week as per the clinical loads have gone up. As of now, we have 158 clinical discussions till the last cases. So far, 288 unique national faculty have participated from across the country. And we have a couple of faculties from Malaysia, Pakistan also. And we have 6,424 subscribed members, of which 1,64,000 students have viewed at various points of times. And of which not fully viewed, starting and stopping in between, we have close to 25 lakh impressions which have happened in our website. So these are the preliminary data, minimal data, which we started as an humble thing. And at this point of time, this is the only platform, I'm proud to say, which do not have any commercial interest and we aim to remain as non-commercial as possible. So all these recordings are permanently available in the YouTube channel. We could see any given time at least more than 40 to 100 of them viewing different videos throughout the day for learning. So with that, I invite the academic committee. I thank the academic committee. I thank the invited faculty. I thank the residents for making this group effort ongoing possibility. And I'm sure we are raising the standards by every week. With that few words, any faculty would like to tell anything, or can we go ahead with the presentation, sir?
Sir, on behalf of the academic committee and myself and Hitesh, we will give as usual a clap. Sir,
Thank you, sir.
anniversary, everyone will give a clap, sir.
Thank you, sir. It is for all of us, I would say.
You started it and we all joined, and you are running it without any flaws, without any comments, and it has been viewed very well and appreciated very well. And as you said, it's available in the YouTube. You recollect, we get the teachings of the great teachers. And all thank you, Kanagvel, and thank you all of you, sir.
Committee members may be Sachin Tendulkar, Lara, but you are breadman, sir.
Thank you, sir.
Long time not seen, sir.
He is in the YouTube, sir. He has some other hospital deputation. So, sir is always in touch with the YouTube.
Please,
So,
sir.
with that, I think we will go to this session. We have two important cases. One is the case of thyroid. Thyroid is a case given by Professor Karunakaran from Madurai Medical College. Thank you, sir. Thank you for giving your PG in such a short notice. And we have one other case given by Professor Pankaj Modi, sir, from BJMC, Ahmedabad. Kaustubh Shah. In fact, I should put on record, they are already having 6 cases waiting for presentation. We'll be taking one after the other. Today, Dr. Kaustubh Shah will be presenting on portal hypertension. So today's faculty, we have the eminent endocrine surgeons and professors from across the country. So let us have the first presentation from Madurai. The plan will be like the candidate is allowed to present first the clinical like history part of it without stopping. The invited faculty can stop and ask questions and correct. I would request the faculty, if the candidate is struggling to answer, please give the right answer. As an examiner, what will you expect from the candidate to tell? And then number 2, then after the examination of the examination part, then candidate move on to the examination part of it. Then once they complete the examination, they are able to arrive at a diagnosis. The initial component can be the clinical finding and the arrival at the diagnosis. And then later we move on to the evaluation part of it, surgery part of it, and the other complication part of it. This is how we plan. The primary importance is to the invited faculty. Of course, the senior academic committee members are welcome to chip in to give their viewpoints also. So candidates, we wish you good luck. And I'm sure it is definitely a big blessing for you to be with us on this day. I would request Dr. Kanagaraj to introduce yourself, your unit chief, your HOD's name, and start your presentation. Over to you, Dr. Kanagaraj, please. Good luck.
Yes, sir. Good evening, sir. My name is Dr. Kanaraj. I am final year PG student, Madurai Medical College. My HOD is Dr. Syed Ibrahim. My guide is, my unit chief is Dr. K. Karunakaran. I am going to start with my presentation.
Please share your screen, Kana.
Yes, sir. Good evening to all. We have 48 years female patient, Bhakyam from Ramnath, Coolie Bay occupation, presenting with complaints of swelling in front of the neck for the past 4 years. Patient was apparently normal before 4 years. Then she developed swelling in the neck, initially small in size, then gradually progressed to attain the present size, associated with history of pain over the swelling for the past 1 year, which is dull aching, not radiating, no aggravating or relieving factors, no sudden increase in size of the swelling. History of protruding eyes noted for the past 4 years, no history of any visual disturbances. History of palpitation present for the past 4 years. History of tremors in the hands present over the past 2 years. History of loss of weight about 20 kg in last 2 years present. No history of any change in appetite. History of diarrhea on and off frequent episodes for the past 2 years. Patient had a history on dyspnea on exertion for the past 1 year. A patient present also had history of sleep disturbances, history of heat intolerance, and a history of excessive sweating. And the patient also had a history of difficulty in standing from the sitting posture and a difficulty in climbing the stairs. No history of hoarseness of voice, no history of dysphagia, no history of syncope, no history suggestive of Horner syndrome, no history of any skin changes, no history of trauma, no history of fever, no history of bone pain, cough with hemostasis, swelling of the skull, or headache or seizures. Past history, patient known case of systemic hypertension for the past 2 years on regular treatment. Patient known hyperthyroidism diagnosed 4 years back and started on anti-thyroid drugs, but patient discontinued treatment 2 years back by own. Not a known case of type 2 diabetes mellitus, bronchial asthma, tuberculosis, epilepsy. No history of any previous surgeries in the neck. No history of any other drug intake. No history of any radiation exposure in the past. Personal history, patient is on mixed diet, no specific addiction, sleep disturbances present in the form of insomnia, diarrhea on and off episodes, frequent episodes present for the past 2 years. She is married, 2 children, all are normal vaginal deliveries. Menopause attained 1 year back. Before that, she had a cycle of 2 days per 56 day cycle, decreased amount of flow, not associated with any pain. Family history, no significant family history of thyroid disorder in the family members.
So,
General-
can I ask you, Dr. Kanagaraj?
Yes, sir.
You said this patient hails from Tamil Nadu.
Yes, sir.
Which part of Tamil Nadu is that? Is that a coastal area or inland area?
Coastal area, sir.
Coastal.
Yes, sir.
And you have gone through the history rather extensively, but I did not hear about the environmental history and family history of and environmental history regarding goiters. Would you like to tell us about that?
Yes, sir. No history of any family members with any thyroid disorders, sir.
Great. But when we talk of thyroid disorders, and especially goiters, including those which may be functional, we should be aware of the environmental history too. If the patient hails from a region which is either iodine deficient or has an iodine excess, or even comes from an area where there may have been any radiation disasters, of course, that is something that you can leave aside because that's not something commonly seen. But always good to know if there is a community history of similar goiters, if there are a number of members in the neighborhood affected. So the reason I bring this up is that instead of simply restricting to family history, we should be discussing the community history too in context of thyroid disorders. And because she comes from coastal Tamil Nadu, this is, of course, this discussion about iodine deficiency is futile. But going back to the presenting symptoms, according to you, which was the first symptom to appear for her?
The patient told us he is noticed swelling first, sir.
Okay. But almost simultaneously, you think the patient had symptoms like palpitations and tremors.
Yes, sir. That's also present with the past 4 years, sir. But
okay. So we will come back to this during discussion of diagnosis, while we discuss the diagnosis, but this chronology is important. I hope you understand why I'm pointing at that.
yes.
Okay. So
డిస్టెన్షన్ తగ్గింది, సాఫ్ట్ ఉంది, టెండర్నెస్ తగ్గింది, అదే డిస్టెన్షన్ తగ్గిపోయింది, మెత్తగా.
Please proceed, sir.
Okay. Okay, please proceed.
Dr. Smriti ma'am and Dr. Swagatam ma'am, do you have any questions, madam?
No, let him continue. Let's.
Okay. Faculty, academic team, anyone, any JLL sir or Kanna sir or anyone wants to ask any questions, sir, at this point of time?
How did you take the history of the Horner syndrome? You said there is no history of Horner syndrome. You have written no history suggestive of Horner syndrome. So how do you take that history, Jay?
Any history of sclerosis or any history of the decreased sweating over the face or any visual disturbances.
Horner syndrome has got so many components.
Yes, sir.
So did you ask about each component in this patient?
I asked about ptosis and anhydrosis. Sir.
Okay. Go ahead with your examination. Yeah.
In the chronology, Kanagaraj, you are mentioning first one is for the 4 years, then you are mentioning something is for 2 years, then again something suddenly you are coming for 1 year. Is that are you going in an order of that? Because you say the swelling for 1 year. Initially, you say there is a 4 years.
I discuss. I am eliciting history about the swelling, sir. So the swelling of pain over the swelling, I consecutively asked the history, sir.
No, if you can go in a chronological order, what has happened first and then then it will be easy to come to a conclusion of the diagnosis.
Okay.
Mixing events here and there will be a difficult one to think of that. And he says diarrhea for 2 years. Somebody is having a diarrhea for 2 years. It's become a chronic diarrheal problem.
We have on and off episodes, sir. Every monthly 2 to 3 episodes of diarrhea. It persists for 2 days or 3 days.
So something related to the thyroid or it's not related to thyroid?
Maybe related to thyroid.
Oh. How do you say it is maybe related? Because it is 2 years. You have a protruding symptom of the eye is already there for 4 years.
Yes, sir.
So suddenly the diarrhea is there for 2 years. What is the change that is happening?
She discontinued treatment 2 years back, sir. There may be aggravation of symptoms after 2 years, before 2 years, sir.
So discontinuation of the treatment comes in the past history?
Yes.
See, once you say something, your patient has been diagnosed for 4 years, the disease. Now you
Yes,
are saying in the past history that it discontinued for the treatment. Is it concerned with the past history? Is it a part of the history you are eliciting for 4 years? See, normally, what is the present history when you are talking the disease onset to the continuous progress? Then you are going to talk about the present history. So this word of that is patient has not continued the treatment or irregular treatment or whatever you feel like that. But in between, you put something as 2 years back as a past history. Again, 4 years back, you are saying a patient was diagnosed 4 years back. Some discontinuity is there. Please make it in an orderly pattern. Whatever you say, it must be in a systematic, orderly pattern. It must go.
Okay.
Why do you ask the history of diabetes here? Any relationship with the hyperthyroidism and diabetes?
I am eliciting for any chronic disease.
That's all. You don't see that is any relationship between diabetic and thyroid.
Sir, in a hyperthyroidism patient, there is a increased basal metabolic rate, sir. There will be insulin resistance is there, sir.
Type 1 diabetes or type 2 diabetes?
Type 2 diabetes.
Type 2. Any peculiar for hyperthyroidism and diabetes? Then if it is any relationship. See, type 2 diabetes, normally you get an obese individual or individual in the age group. Here, that this hyperthyroidism in a younger age group. You are thinking in terms of autonomic disease.
Yes. Yes, sir. Graves' disease also is an autonomic disease. So autoimmune diseases or type 1 diabetes is also presented with the.
So don't say you are just for the sake of ask any history. All the history you are asking, all the past history you are asking, something related, and it is for the some purpose only you are asking. Not as it's a
Okay.
casual relationship. There may be some relationship with whatever you are asking for that. So what are the associated metabolic changes happening with when you are suspecting thyroid? Also, you must be taken into consideration for when you are asking the history. Okay. Go.
Okay.
You talked about this patient has history of diarrhea, you said. Is
Yes,
it
sir.
actually diarrhea? Did you try to look at this rather in a more detailed way? Is it actually diarrhea or simply frequency of stools?
Increased frequency of stools, sir.
And so if you, as Dr. Jailal said, if this increased frequency of stool is something to do or something related to the primary condition this patient is having, how does, I mean, where does it fit in? What further details of this increased frequency of stool you need to do or tell us about to exclude or to rule in this as a feature of hyperthyroidism per se?
Sure.
Okay, so the answer is that you're right. This patient simply had increased frequency of stool and not really diarrhea, because if it is not associated with any features which may suggest an infective pathologic cause or even a secretory cause, hyperthyroidism results in just increased frequency and not diarrhea. Okay,
Okay.
is that what you meant? Okay, let's go ahead.
On examination, patient is conscious, anxious, restless, oriented, afebrile, poorly built and nourished, no interest, no clubbing, no pedal edema, no generalized lymphadenopathy, skin warm, moist and shiny, tremors, fine tremors noted in the both hands. On eyes, there is a Stellwag sign present, Mobius sign present, Van Graaff sign present, and Joffre sign present. On vital examination, pulse rate, 90. Yes, sir.
Hold on. So, well, it's not something which will make or break the diagnosis, but still it is a good idea, a good habit to start with the vitals. You said the patient's consciousness and general examination, but okay. And these signs that you are mentioning here, the eye signs,
Yes,
what do you
sir.
mean by all these? What is Stellwag sign?
Stellwag sign means infrequent blinking, the staring look, sir.
Is that okay? And Mobius?
Unable to converge the eyeballs.
I think, I mean, as I personally believe that the names are not so crucial. It really doesn't make much difference if you name them or not. But what you should know is what is the logical progression of eye disease in a patient where, I mean, it's quite apparent that we're dealing with a patient with hyperthyroidism. And if there are eye signs associated with symptoms of other symptoms of hyperthyroidism, then there should be a logical sequence or logical progression of presentation in terms of, so what is the first eye sign to appear in a patient who has hyperthyroidism? Why will it come? Okay.
Lid retractions.
Lid retraction. Okay.
Yes.
All right. And then?
Dalrymple sign is appeared first, sir. Lid retraction.
Dalrymple sign first.
Think again.
Dalrymple sign first.
So the okay, do you think it is important? Do you think it makes any difference to the diagnosis? Okay, let me go back to the first finding that you've written is the patient has exophthalmos. How do you assess for exophthalmos? I mean, how did you examine this patient? In what position?
Patient in sitting position, look for upper and lower sclera. If that is visible or not.
Yeah, so this picture that you're showing us today, right
Yes,
now,
sir.
the upper sclera is not visible.
Yes, sir.
Okay, so
I did.
that is fine. And then next, what do you do? How do you examine for exophthalmos or proptosis?
There is a Nagel's exophthalmometer is used to
We are only
for
on the
exophthalmos
examination.
We'll come to that a little later, but on clinical examination, so besides just trying to look for the sclera, which
Yes.
may or may not be there, as
What do you do next?
Any other method of examination for exophthalmos, looking from above or something you do normally?
Not aware of.
Nepsiker method, have you heard?
Sir? Yes, sir. Navisiker method.
Yeah, how do you do that?
From standing behind the patient, he asks the patient to extend the neck and look for any protrusion of eyeballs.
So protrusion can be also exophthalmos or any retrovalvular mass also. How you differentiate it is due to thyroid or due to retrovalvular mass?
Yes, sir. There proptosis is present due to any local causes. Exophthalmos is present as a endocrine disorder or any systemic disease, thyroid disease. There will be in proptosis there will be no blepharospasm, sir. But in
method of examination will be able to.
Also, what probably sir is asking you is that if you see from the upper face, and you should see that the upper eyebrow, the eyeballs are in a straight line. And if it is above the line, and then probably, I think what sir wants you to answer is that, it should be exophthalmos. And if the entire upper palpable conjunctiva, the eyelid is along also out, in that case, it is a retroorbital mass that is pushing it out or something like that. I think is that the answer?
Be associated with the lid retraction. That is how Mullers muscles goes for the.
Yes.
So
Yes,
you will
sir.
not be able to retract the upper eye.
Retract. Yes, sir.
The eyelid will not be possible. Can you
Yes,
get a lid retraction in a secondary hypothyroidism?
Secondary hyperthyroidism, there will be eyes are very minimal, sir. There is no lid retraction in the blepharospasm in the secondary hyperthyroidism. Sir?
What is the cause for lid retraction?
There will be hyperactivity of the Muller's muscles, sir. It's a part of levator vertebrae superior that is supplying to the post-ganglionic fibers of the superior cervical ganglions.
So that is due to the sympathetic overactivity. It is
Sympathetic overactivity.
Your antibodies, nothing to do with Graves' disease. So anywhere
Yes.
you have a sympathetic overactivity, there is a possibility you can have that. So
Okay.
these signs, which is particularly due to the hyperthyroidism, due to the systemic, sympathetic overactivity, can present in any thyroid. There is nothing particular. These are not as particular lesion only present in the Graves' disease.
Okay.
And before that, just because we thought of this, but the first slide you said patient is poorly built and nourished. We think she is poorly built. And what ground you are saying she is poorly built? What is built?
Built means there is a bone mass. The nourishment is a muscle mass.
No, you are mentioned is a poorly built. How do you justify your statement she is a poorly built? Just because she is a patient, she is not a poorly built. So when on a PG, when you are writing, you must be very careful what the word you are using. When you are putting is a poorly built and nourished. So that means fundamentally you are not looking at the patient as a whole. Okay. Okay.
One more thing to clarify for Nevziger sign, you have to specify the superciliary ridge plane. That is different from forehead. This is forehead, and there are two ridges of the superciliary region. So you have to make sure that you are not looking at this plane. You have to extend little more, and you have to palpate this superciliary ridge and the eyeball should be protruded beyond that. That is what the sign literally means. It may not differ much, but this is what literally it means.
Okay.
I'm sorry I got disconnected for a while, but yes, so I think we have devoted sufficient time to eye science, but would you like to tell us about what is the pathophysiology of eye science in Graves' disease?
Yes, sir. There, in Graves' disease, there will be an increase in thyroid stimulating antibodies. Sir. There is a cross immunogenicity between the thyroid antibodies and orbital fibroblasts. Sir. There will be a inflammation and the cytotoxic antibodies and cytokines produce inflammation, and there will be a deposition of glycosaminoglycans and collagen in the retroorbital areas. That is very hydrophilic. So there will be a edema and inflammation in the retroorbital region and orbital fibroblasts. That will produce the eye signs.
So just deposition of the retroorbital fat that would cause proptosis,
Yes,
but then why do we see in rest of the eye signs the lid lag, which is the first sign to appear, then lid
yes,
retraction. Lid retraction is more of a manifestation of exophthalmos per se, and
yes.
then other eye signs. What is the basic pathophysiology? Of course, you're right. Inflammation is there, causes what?
Cytotoxic destruction of orbital fibroblasts.
Yeah.
There is a cross immunogenicity between thyroid gland and orbital fibroblasts due to.
Agree that you said, and you're right.
Yes.
But what you have to remember that by itself, this inflammation doesn't result in the eye signs. It's these inflammatory changes, they cause weakness of which muscles?
Okay, sir.
Which of the muscles? I mean, these are all essentially signs due to weakness of certain muscles. Which ones?
There is initially inferior oblique and superior rectus is affected, sir.
Good. Okay. So let's proceed then. We have discussed the eye signs. Would you? It would be good to know the BMI. If I agree with Dr. Jailal that saying a patient is poorly built is quite subjective. So if you can tell the patient's BMI, if you have examined the patient, you could have well calculated the BMI, and that would tell us the exact objective assessment of the patient's build and nutrition.
Okay.
Okay, please go ahead.
Yes. Examination of a butterfly shaped swelling 8 x 5 cm descending in front of the neck. Surface appears smooth, moves upward with deglutination, not moves with protrusion of tongue. Skin over the swelling, dilated veins present, no scars, no sinuses. It extends 2 cm below the thyroid cartilage and 2 cm above the sternal notch and 1 cm medial to both anterior border of sternocleidomastoid. Margins well defined, plain, deep to deep fascia, lower border is visible, trachea in midline, no cervical lymphadenopathies. Yes,
so this lateral, so you keep this projected for a while. We'll come to the neck examination, but because you have now projected a lateral picture too, so
yes,
exophthalmos, this is when I got disconnected, so I couldn't complete at that time. So do not comment on eye signs without examining the patient in at least 3 planes. That is, from the front, as you would like to see the sclera, from the sides, as you are seeing this patient now. Protrusion of eyeballs is more visible from a side view, and then do the Neftiger's maneuver or test, whatever you will like to call it, to see it from the top. And now going to the neck examination, you have said that this is a butterfly shaped swelling. Keep the picture projected for a while.
Yes, sir.
Yes. Well, I do not see a butterfly on the neck in this patient, but perhaps with some bit of imagination, one can agree that this is butterfly shaped. Okay, but then something even more prominent or something very startling, which I did not hear from you on inspection of the neck.
Sir, the patient is extends his neck, sir, so the swelling become less prominent, sir.
All right.
Yes,
The patient is asthenic. You can see the supraclavicular fossae, they are so sunken, and
yes,
that, yeah. So the patient is asthenic, looks asthenic. Of course, I would need to know the BMI to be absolutely certain about it. And you have really prominent neck veins, at least few of them. They are prominent. I'm not calling them tortuous. I'm not calling them pathological, but certainly prominent. Okay.
Yes, sir.
You go ahead.
Yes. Examination of the palpation, warmth over the swelling present, not tender. All inspectory findings are confirmed. Consistency firm, mobile in all directions. Lower border of the swelling palpable. Trachea in midline. Both carotid sparkle and normal position. On co-chestus, there is no stridor. Palpable thrill over the swelling present. There is no regional lymphadenopathy.
Hold
on percussion.
Please.
Yes, sir.
What is Cocker's test? Is there a test named after Cocker? Should you be doing it?
Sir?
You have put as the first sentence of the warmth.
Yes, sir.
The heading is examination of the neck. Now comes warmth. And what do you mean by that?
There is hyperdynamic circulation in the thyroid, sir. So the swelling is warmth, sir, comparing to the surrounding.
No, your heading is examination of the neck. And now you are...
Yes, sir. There is palpations.
You mean to say local rise in temperature?
Yes,
okay.
sir.
Yeah. Okay. Yeah. But I'm asking you about the Cocker's test. You have written Cocker's test you've done, and there's no stridor.
Yes, sir.
It's a inhumane test to do. And a patient,
yes, sir. On comparison swelling between the thumb and the other fingers, there will be a stridor, sir.
No, this is something you should not try to do. Should not elicit. I mean, there are other ways of assessing the adequacy of airway. If the patient doesn't have a stridor,
okay, sir.
Do not induce stridor.
Okay, sir.
Please. Okay.
Okay.
How did you test the mobility of the swelling?
After the fixing the trachea and look for mobility of the swelling in both horizontal and vertical direction.
You are fixing the trachea?
Yes, sir.
How?
How you are going to fix?
With the opposite hand, I will try use pressure over the trachea, sir.
Why do you need to do that? Trachea is a reasonably fixed organ. I mean, it's not a floppy thing, or it doesn't keep moving around. That's a landmark. Why do you need to fix the trachea? Okay.
Did you do some ask the patient to deglute or anything? This is just a hint for you.
Huh?
How did you examine the mobility? You said mobile in all direction. So how did you examine the mobility? So what did you ask the patient to do? First, to confirm that it is a thyroid swelling, the basic test.
Yes, yes, ma'am.
What did you ask the patient to do? To confirm that yes, it is a thyroid swelling.
Most with the deglutinations.
Deglutination. So that, and then you had tested the mobility. How did you test the mobility? What did you do? You cannot fix the trachea, no? So how will you test the mobility?
Keep the thumb and other fingers for the swelling and look for both horizontal and vertical mobility. 。  . 。  . 。 . 。 . 。 . 。 . 。 . 。 . 。 . . 。 . 。 . 。 . . . . 。 . . 。 . 。 . . . 。 . .
。 . . 。 . . 。 . 。 .
。
up down movement only by deglutition you have done it, and side
Yes,
to
sir.
side you will hold the. You will test from side to side. How will you test from side to side? You are right. Come on.
Yes. Yes, ma'am. I keep the hand over the thumb and the index fingers, or thumb and other fingers over the swelling, and move the swelling side to side to look for the mobility, ma'am.
And how will you ask the patient to extend the neck or flex the neck?
Flex the neck, ma'am.
Extend it. Okay.
Anaraj, I heard that you say declutination. Is it deglutition or declutination? Is that both are same or different?
Sir?
Deglutition or declutination?
Degglutination.
Degglutination.
Degglutination, is that process is called degglutination?
No, sir. Degglutination.
Deglutition. Deglutition is a different process. It is nothing to do with our anatomical structure.
Okay.
And why do you want the, I mean, you do Caucus test to see whether they, after the surgery, whether trachea will collapse or not. No, that is, why do you want the trachea to be always kept open? Or ear to be always kept open? Esophagus is not kept open always. Only when you eat, it will be open.
Yeah.
What is the purpose you are expecting? The if it is when you are breathing itself, it's enough, it is opens and is it not enough? Why do you want it to keep it always open?
Yes. I want it keep it open always, sir.
What is the reason? What is the physiology begins there?
That is, every breath there is a air exchange between the lungs and the nose.
So let in for every breath, let it open, and other times it can collapse. Yes, you
So
are.
if any tracheal involvement, there will be an increase in
This is a dead
in the
space.
appearance of any strider.
Kanagaraj, understand what is the dead space?
Sir?
What is the tidal volume and what is the dead space?
Dead space is there is no air exchange between there will be no air exchange, sir, between oxygen and carbon dioxide.
So what is that space? So out of what is the tidal volume? Total tidal volume?
Tidal volume is 500 ml. Sir.
So out of which is 150 L till the oral cavity to the your alveoli where the exchange is taking place. That part of the air is not taking place. See how many times air exchange is taking place in the lung? Is it in response to the respiratory tract or it is the cardiac rate?
It's a response to cardiac tract.
So cardiac cycle is you have 72 beats.
Yes, sir.
So that is 72 times it has to take place. The space in the dead space here will be, it is helping us in the extending, maintaining that exchange. So we need to have always the trachea to be kept open.
Yes,
like esophagus, if you cannot open it only for the food. That is why we are very particular of the tracheal collapse if it occurs after the Caucus test, which is not, as Sir has already said, you are not supposed to do the test in any postgraduate examination. Please do not mention that.
Okay.
Realize that why you want to do you want the trachea to be prepared. What is the shape of the normal trachea?
Sir, in the lumen.
Yeah, what is the shape? It is a C shape, it is a D shape. What is the shape?
It's a D shape.
Okay. What is the posteriorly? What is bounded by? Anteriorly, the curve of this E is by the cartilage.
Yes, sir.
Posteriorly, is it a cartilage or it is a ligament? It is a muscle. When you say D shape, there must be a round and then there is a flat part. That is what was a cartilage happening or it is a muscle?
Muscle, sir.
Okay, go ahead.
Okay, how will you palpate the lower border of the swelling? You have said it is palpable. Suppose if it is not palpable, what maneuver will you do?
Ask to ask the patient to swallow, ma'am, degglutination, and look for the lower border, ma'am.
If you are not able to palpate the lower border of the swelling, you are not able to go below the swelling, then what maneuver will you do? What will you ask the patient to do so that you can, or in other words, how will you rule out a retrosternal extension of the goiter?
Yes, ma'am. Initially, ask the patient to swallow, ma'am. If any,
And something
I
else?
and ask the patient to cough, ma'am.
Do you know what is Pemberton's test?
Yes, ma'am.
How will you do it?
Ask the patient to raise the arm above the head, ma'am, to look
So?
for any congestion or distended veins or pain appearing over the.
So what does it rules out?
There is a thoracic outlet is obstruction or not.
So,
superior vena cava is obstruction or not.
So in a patient of neck swelling?
There will be intrathoracic extension.
Intrathoracic extension. Okay.
Kanaraj, what is thrill?
Thrill means palpable pulse.
Is palpable thrill? You have mentioned as a palpable thrill. Is there a non-palpable thrill is also there?
No, sir.
Because in the case sheet it is shown as palpable thrill plus. I am wondering
Yes,
whether
sir.
there can be something called non-palpable thrill.
No, sir.
Where did you look for the thrill?
The upper pole of the thyroid.
Upper pole of the thyroid.
Yes.
Feel a thrill here clinically.
Yes, sir.
So you are highly sensitive fingers you are having. Okay, go ahead.
And, on percussion, there is a resonant note over the sternum. On auscultation, the bruit over the swelling is present. The spine and cranium normal. Systemic examination, CVS, S1, S2 here, no murmur. RS, bilateral air entry present. CNS, no focal neurological deficient present. Power, tone, and deep tendon reflexes are normal in both upper limb and lower limb. Upper abdomen, soft, bowel sound plus, no organomegaly.
You said there were tremors in the hand, but still you say there is a tone, everything you tested very absolutely normal.
Yes. Yes.
Whereas in the symptoms, you did say that the patient has complaints of difficulty in standing
Yes,
from
sir.
squatting posture.
Yes, sir.
So that's a very peculiar symptom of
Yes, sir.
proximal muscle weakness.
Yes, sir.
But then fortunately, this patient didn't have any dystonia or any loss of muscle power.
Yes, sir. On examination, there is a power 5/5 is there.
Okay. Okay, let's move ahead.
On summary, a 48-year-old postmenopausal known hyperthyroid female patient presenting with swelling in the neck for the past 4 years with features of thyrotoxicosis without any history suggestive of malignancy. On examination, the diffuse enlargement of thyroid without any cervical lymphadenopathy. A diagnosis, toxic non-malignant diffuse goiter, Graves' disease.
Would you call it toxic goiter? What is meant by toxic goiter?
Means
When
that
you use the word thyrotoxicosis.
Yes, sir.
Is that the right term to use? Hyperthyroidism or thyrotoxicosis, which is a better word
And
to use?
no need to add non-malignant.
Okay. Okay. It's a toxic, sir. The clinical or biochemical manifestation of a hyperthyroidism is thyrotoxicosis, sir.
Clinical manifestation of hyperthyroidism.
Yes, sir.
Is thyrotoxicosis.
Thyrotoxicosis.
Yeah.
Yes, sir.
So,
yes.
And not biochemical. There is no biochemical manifestation. Biochemical evidence is hyperthyroidism. Okay. So, is it a primary hyperthyroidism or secondary hyperthyroidism?
Primary hyperthyroidism.
So, should that not form the a part of this diagnosis?
Sir?
Should that not form part of the diagnosis? So what I'm suggesting is,
Yes, primary.
the phrase to use is the patient has 4 years history of symptoms which are suggestive of hyperthyroidism and resulting in thyrotoxicosis, and 4-year history of a neck swelling. So chronologically, going just by the chronology of the disease, this is primary hyperthyroidism. And
Yes.
if you've used the word Graves' disease, the phrase Graves' disease. If you're
Yes, sir.
using this phrase, then of course you mean primary hyperthyroidism. Graves' disease
Yes.
is secondary. Okay.
Yes, sir.
And then you have used this the phrase non-malignant, or in other words, it would have been better to say benign. Is there any finding in your history and examination which is suggestive or even remotely suggestive of malignancy in this patient?
No, sir.
No. So you are reasonably certain of this being benign. So if
Yes,
at
sir.
all you want to include a statement regarding whether the swelling is benign or malignant, it should be benign and not non-malignant.
Okay, sir.
So primary hyperthyroidism
Yes.
with goiter
Yes,
and
sir.
which is benign. This is what you want to say? Okay.
Okay, sir.
And in what way, how do you defend this diagnosis of Graves' disease? Why is it Graves' disease?
Yes, sir. Patient has symptoms of thyrotoxicosis, sir, with ophthalmopathy with a goiter, sir.
Good. So primary hyperthyroidism with eye signs,
Yes,
and
sir.
I agree, eye signs, presence of eye signs, the first diagnosis would be Graves' disease. But is
Yes,
this
sir.
the only diagnosis you would entertain? Is this the only diagnosis you entertain? And in favor of Graves' disease, what are the other findings in your patient?
Patient had a tremor, sir, and a goiter.
Mhm. But the patient also has palpitations. If
Yes, yes, sir.
tremors, so presence of tremors favors the diagnosis of primary hyperthyroidism. I agree. And so
Yes, sir.
what else?
There
What
is
is the
there diffuse enlargement of swellings, thyroid, sir.
good? So you are suggesting this is a non-nodular
Yes,
goiter?
sir. Yes, sir.
Okay. How frequently is in a patient who has Graves' disease? How frequently can you encounter nodularity in the thyroid gland, or is presence of nodularity?
In Graves.
Yeah.
Yes, sir. There is a very minimal chance, 1 to 2% chances of getting nodularity in the Graves' disease, sir.
1 to 2%. Think again. 1 to 2%. What is the incidence of thyroid nodules in general population?
In general population, it's in female population there is a 5% chance of thyroid nodules.
Okay,
In male,
we
there
are
is
talking
1%.
of if it will differ from region to region, geographical region to different. It may differ, and in majority, if majority of North India, in postmenopausal women like the one that you're presenting,
Yes,
30% women would have thyroid nodularity. Not everybody would have a clinically apparent one, but thyroid
okay,
nodules are common.
okay,
So presence of thyroid nodules per se do not exclude or do not rule out the diagnosis of Graves' disease.
yes,
But
sir.
if in case the goiter is diffuse, as you have said your patient's goiter is, then
Yes,
it favors the diagnosis of Graves' disease.
yes.
Okay. And is it actually a smooth surface in a patient who has a long-standing Graves' disease and a significant goiter? This is a grade 2 goiter. Uh, is it actually totally smooth goiter, or is there something else? The surface is usually bosselated. It's not nodular, but bosylated. How do you differentiate the two conditions? So if you find that the surface of the goiter is not entirely smooth,
Okay.
you need to be sure whether it is nodular or is that lack of smoothness simply because of bosylations. How do you differentiate the two conditions? So the difference between nodularity and bosylations is that nodules are rather discrete and you would be able to feel some bit of indentation and even at times normal consistency thyroid tissue in between them.
Okay.
Whereas bosylations, these are simply indulations of the surface. These are not discrete and you would not be able to feel such a the difference in consistency in between the uneven surface of the thyroid gland. So importance of this finding is that bosylations are common thing. Bosylations are common in long-standing Graves' disease. And why does the thyroid gland become bosylated? If the disease is that of a diffuse hyperplasia of the gland, then the gland surface should be smooth. But more often than not, we find when you operate, we take out the goiter in a patient with Graves' disease, we find it's indulated or bosylated. Why does that happen?
There is a autonomy of growth and function of the follicles. Variable response of the follicles to the TSH stimulations.
Well, that's the pathophysiology of nodularity.
Yes,
we are talking of a non-nodular diffuse goiter that we see in Graves' disease, and yet the surface is not entirely smooth, it is bosylated. It is just to do with the surface vascularity. The surface vessels, they do not allow the goiter or the thyroid to enlarge uniformly. So in a way, these surface vessels act as kind of restraints, and in between these vessels there is unrestrained growth, and that leads to kind of a bosylated appearance, which can be felt, which can be palpated, and it will be seen on when you take out the specimen on gross pathology. You find the surface is bosylated. Okay, so my question to you, you've not answered yet. Is this the only diagnosis you will entertain? Can there be any other diagnosis?
There may be a toxic MNCs. There may be non-palpable nodules in the thyroid glands.
Okay. So this may actually be toxic multinodular goiter. This is what you're saying, or toxic autonomous nodule.
It's a toxic autonomous nodule. There will be a discrete nodule in the thyroid glands.
Yes. Okay. So you're saying that this because this patient has a diffuse goiter, so nodularity is excluded, but this patient may still be having nodularity, which is non-palpable. Agree.
Yes, sir.
So though this patient, because there is no nodularity, the probability is low, but one cannot, presence of eye signs and primary hyperthyroidism features do not completely exclude the possibility of toxic multinodular goiter.
Okay.
Any other differential diagnosis you want to discuss? If none, fine. This is because you have constellation of three very crucial features which all contribute to the diagnosis of Graves' disease. It is totally acceptable. You can say that. I mean, the reason I'm asking this question is to assess whether you're confident of this diagnosis or not. What is the constellation? I said there's a constellation or coexistence of three different crucial features. What are those three crucial features which contribute to the diagnosis of Graves' disease?
The eye signs and the diffuse enlargement of the goiter and the tremors.
Well, you may do not put too much emphasis on tremors. All in all,
ophthalmic eye signs.
Sorry. Can I say something, sir? Here.
Please go ahead.
You said eye signs.
Yes, sir.
I would like to differ. Eye sign is not the word you should be using if you are putting a diagnosis of Graves' disease. Why?
Because the ophthalmopathy is.
Pardon?
Ophthalmopathy is.
So what we say, Graves' disease is a primary thyrotoxicosis, in other words, right?
Yes, sir.
Suppose there is a secondary hyperthyroidism. Will there be eye signs?
No, sir.
There will be. What are the eye signs which will be present in secondary hyperthyroidism?
Only there is a lid lag.
So it is not eye sign?
Yes, sir.
So remember, eye signs will be present in both primary as well as secondary. But there is a certain eye signs which is present only in a primary. What is those? Because remember, there are two things. One is eye signs due to sympathetic overactivity, which is inherent, which will be present because of increased level of T3, T4, which will be present in primary as well as secondaries, right? But there are certain eye signs which are exclusively in Graves' disease. What are those?
Stellwag signs.
No, I don't want a name.
Yes, there is a lid retraction, sir.
No. You are confusing it. The eye signs due to other than sympathetic overactivity.
Yes.
What are those signs? In other words, what is exophthalmos?
Exophthalmos is a protrusion of the eyeballs.
What is proptosis? What is proptosis?
The protrusion of the eyeball due to any local cause is proptosis.
So when there is a protrusion of eyeball due to thyroid region is a exclusively in thyroid disease. So why there is exophthalmos? Why there is exophthalmos?
There is a retroorbital inflammation and edema.
Yes. Whatever it is, round cell deposition, there are various theories, right?
Yes, sir.
So that is exclusive in primary hyperthyroidism. Why?
Yes, sir.
Why?
There is a cross immunogenicity. There is a cytokine. Yes. There is a orbital fibroblast inflammation and cytokine and cytotoxic antibodies. There will be a inflammatory destruction of the.
Right. So that occurs only in a case of autoimmune disease.
Yes, sir.
Antibodies acting on thyroid will also acting there. So there will be presence of exophthalmos, which is exclusively in primary hyperthyroidism, along with the sympathetic overactivity, which will be present in both cases, primary as well as in secondary. So when you say loosely use word eye signs, it is not a proper. It should be exophthalmos ideally. There are certain signs exclusively of sympathetic overactivity, and there are certain signs which are because of exophthalmos. What is malignant exophthalmos?
There is a more than 20 mm of protrusion of the eyeball is malignant exophthalmos.
So only the protrusion which decides. What else? There is the signs of extreme exophthalmos like a chemosis, diplopia, and that is right. Anyway, so when you say sir is asking constellation, are the best is you should use word exophthalmos rather than using word eye signs, which will be you are not totally wrong, but not totally right, like that. So you should everybody should understand the difference between sympathetic overactivity leading to eye signs, which is confined to levator palpable superior. So it will give rise to wide palpable fissure and difficult to retract. Others are because of the combination of retrobulbar deposition, ophthalmoplegia, involvement of the muscles. Please continue.
So the diagnosis, I have agreed with this diagnosis, but I'm telling you that this is not a complete diagnosis. Dr. Modi has very correctly pointed out that you must also include Graves' ophthalmopathy. Exophthalmos is a maybe synonymous term, but in this patient we are dealing with Graves' ophthalmopathy. And are you aware of grading of the Graves' ophthalmopathy?
Yes, sir.
How do you grade the ophthalmopathy?
There is certain scoring system is there. The clinical activity scores. Sir.
Good.
Yes, and the no specs scoring.
Okay, so because I am looking at the clock, it's already 9. We'll not go into details of those. So
yes.
you have this diagnosis of Graves' disease,
yes,
and we have the three components: primary hyperthyroidism, a goiter, which I would have liked you to quantify, and in terms of grading, and thirdly, Graves' ophthalmopathy.
Okay.
These are the three components this patient has manifested with. How would you confirm this diagnosis?
I want to do the thyroid function test and thyroid thyroid peroxidase antibodies.
What do you mean by thyroid function test?
So TSH and T3 and T4, so free T3, T4.
Well, it's not such a great idea to call them thyroid function test anymore. This term thyroid function test was relevant when we did not have direct estimation of thyroid hormones as we do today. At a time, perhaps 3 decades and 4 decades ago, when these assays were not commonly available, you would do indirect estimation or indirect assessment of thyroid function, and that is why it used to be called thyroid function test. Today, you have direct estimation of thyroid hormones. So you say that I would like to assess, or I would like to assay the use. And now, which ones do you want to assay? Or
TSH.
First thing you would like to do is TSH, okay?
Yes, sir.
And in a patient who has features of hyperthyroidism, is TSH sufficient, or would you like to do more?
TSH is sufficient enough to tell it's hyperthyroid or hypothyroid. Yes.
I would agree with you that TSH is sufficient to differentiate euthyroid versus hypo or hyperthyroid.
Yes,
perhaps, yes. But in a patient who has symptoms of hyperthyroidism and going to be treated with antithyroid medications almost certainly.
Yes, sir.
I feel it is important that we assess not just this, but also free T4 levels,
yes, sir.
or else total T4. And when would you assess T3 as well? Of course, this patient has manifest hyperthyroidism, but is there a role for assessing T3 too?
Yes, sir. If reports TSH is suppressed and T4 cam is normal, there will be a T3 toxicosis. So we need to assess.
Usually, which kind of hyperthyroid condition you would expect T3 toxicosis? Primary versus secondary, diffuse versus nodular. Okay, is it getting too much about thyroid hormones? Okay, so the minimum that I think you should say while doing thyroid hormone estimation in a patient with Graves' disease is free T4 and TSH. You may not need to do T3 in all patients, but if the T4 is equivocal, then of course you would like to do that. Okay, this is the first thing you rightly said you would do. And then you were talking something about some antibodies. Which antibodies do you estimate?
Anti-thyroid peroxidase antibodies.
All right.
Yes.
Anything else?
Anti-thyroid stimulating hormone antibodies or thyroid receptor antibodies.
Thyroid receptor antibodies. When is that of some help? Anti-TP thyroid peroxidase antibodies or TTPO antibodies.
Okay, sir.
When would TSH receptor antibodies, when would they contribute to a diagnosis?
There may be a difference between Hashimoto's thyroiditis and Graves' disease.
So at times, this again, in this patient, you have a long history of consistent features of hyperthyroidism and goiter. not waxing, waning, not giving rise to a confusion between Hashimotoxicosis versus Graves' disease. So perhaps it is not important in discussion of this patient, but be cognizant that of the fact that hyperthyroid features or thyrotoxicosis in any patient is not straight away or not synonymous with Graves' disease. All right.
Okay.
So we have estimated the thyroid hormones and we have estimated the antibodies, anti-TPO antibodies. What next? What else do you like to do? Would you like to do in this patient to confirm your diagnosis?
There is, I want to do thyroid scintigraphy.
Okay. What do you mean by thyroid scintigraphy? What?
Technetium 99. Technetium 99 scans.
No, that's not correct. Technetium 99 by itself would not help you do a scintigraphy. What is the substrate used? That is just the radiopharmaceutical.
Technetium 99 pertecnate, sir.
Excellent. So the answer should be technetium 99 pertecnetate scan.
Yes.
Then some people may say that I like to do radioiodine scan. What is your take on that?
So there will be a delay in getting the results, sir. And if are planning to do any radioactive ablation, there will be a delay in treating the patient, sir. There will be a stunning is presence.
Good. So would you, what if I say no, there is a possibility of doing a radiation scan without much other issues, without causing any delay, significant delay?
Yes, sir. There is
what radioiodine, which molecular radioiodine is used for a diagnostic scan? That depends. I mean, that will determine whether it will cause delay or not. So if you have access to iodine 123, which is a cyclotron product, and you may do it right away. But usually, most Indian centers, they use radioiodine, iodine 131. There, of course, you would have to block. I mean, this would cause considerable delay and everything. But pertecnetate scan is good enough. What is the difference between the two, pertecnetate scan and the radioiodine scan?
In pertecnetate scan, there will be only iodine trapping is there, sir. But in iodide scan, there will be a trapping and organification of the iodine is there.
Excellent. Very good answer. So that is the difference. All right. So we have a message from Dr. Kangavel that we have to close this case in 10 minutes.
Dr. Kanagwaj, why do you want to do scintigraphy?
To look for the uptake of the glands.
No, that's fine, but why?
Yes.
Obviously, it will show the uptake, but is there any reason to submit this patient for that? What is the indication of doing that pertecnetate scan in this patient?
If any suppressed TSH with any nodularity, there will be a definite indication of doing pertecnetate scan.
I don't get it. What did you say?
If there is a suppressed TSH with nodules in the thyroid, it's an indication of thyroid scintigraphy scans.
So you will do sonography first?
No, sir. There will be a suppressed TSH. Now we can proceed with the thyroid scintigraphy.
No,
but why? I agree.
Why?
Why?
If there is any autonomically functional nodule, the treatment plan will be changed.
Okay. Anything else?
Yes.
Yes, sir. There will be a hemithyroidectomy for any autonomic function.
This patient has a diffuse goiter.
So there is no question of hemithyroidectomy. What is the age of patient? Sorry, I was not present initially.
48 years.
48 years. Male or female?
Female.
Female, 48 years. Right. And diffuse toxic. So there is no question of any nodularity as far as your clinical and that examination go. So the hemithyroidectomy or autonomous is unlikely. So why do you want to do scintigraphy? So normally we don't do it. That's why I would like Dr. Gaurav to say anything, because we normally don't do if the diagnosis is in doubt. There are certain indication for doing it.
Yes,
I agree. It's not something which is essential. It is not something which adds a great deal to the management of the patient. The only way it may help is if in case it shows you a photopenic area, a cold nodule, then you can target it to do a FNA. Usually in such a goiter, which is toxic and which is diffuse in nature, you would not like to do any FNAs preoperatively. But if the patient has a photopenic area, a cold nodule, the probability, conventionally it is believed, the probability of malignancy goes up. And so you would like to do a guided FNA from that cold nodule. In case it is either suspicious or diagnostic of malignancy, then it helps in decision making in the way that you would definitely like to operate this patient and not treat her with radioactive iodine. Okay, we'll come to that part a little later. But ultrasonography today is good enough. It provides us more information, to my belief, than a technician's scan. And it is free of any, it is logistically easier to do, cheaper, free of any radiation. And then if there is nodularity, you can characterize the nodules, whether they are malignant, benign, or suspicious. Okay, now we have, because we should be winding up this case. How do we treat this patient? Very quickly.
In Graves' disease, we started with the antithyroid drugs.
What drugs?
It's carbimazole and propranolol.
Okay. This patient, in this particular patient, 48-year postmenopausal lady, what would you like to do?
After controlling the symptoms, we proceeded with surgeries.
Oh, so surgery is the only definitive treatment in this patient?
It's a radioactive ablation is also.
Okay. So I think
Dr. Kanakwal, do you understand what sir is asking? You should be very clear on your thought. That's why I ask only two questions: gender of a patient and age of the patient, and your diagnosis is diffuse toxic. So what would you do first? You should be saying, sir, after control of a hyperthyroidism with antithyroid drug, I will proceed either surgery or radioactive iodine. What will you prefer? Ablation you will prefer or surgery you will prefer? Don't change your surgery. Why?
Sir, if you have more than 45 years, patient age is more than 45 years, post-menopausal women.
So surgery is preferred. Why?
Yes.
Reason?
It's there will be say immediate cure. There will be immediate cures.
So why you want immediate cure? So we are short of time. Let me tell you. The point is there are certain in a Graves' disease. At present, treatment of choice is a ablation. Understand? Unless there are exceptions like age, childbearing age, right? Certain contraindication or thyroid, which is a large swelling. Do you understand? Which does not equal. So, why do you want to do surgery in this patient? Again, I'm asking you. There is a one definite indication, cosmesis.
Yes.
So, is that an indication in this patient? So, why would not like to, in other words, why would not like to radioactive ablation?
So in interest of time, let me just take one step back and remind Dr. Kanagraj and all the postgraduates. See, definitive treatment either with radioactive iodine or with surgery is not essential in all patients with Graves' disease. In fact, the first step, first line treatment is simply antithyroid medications. if we consider all patients with Graves' disease, many of them are non-goitrous. They do not have any enlargement of the thyroid at all. And they simply have primary hyperthyroidism. They may not have any proximal muscle weakness, or they may not even have any eye signs. And these patients, a large proportion of them would go into remission with 6 months of antithyroid medications. So why do you even bother to do radioactive iodine ablation or surgery? But then there are certain indications for definitive treatment with one of these two. And the indications by and large are patients who relapse after radioactive or after antithyroid medications. Number two, patients who have large goiters. Your patient, the one that you have presented, belongs to this category. Patients with exophthalmos or ophthalmopathy. And now comparing the two modalities of definitive treatment, radioiodine versus surgery, in which patient would you choose what? A young patient in childbearing age who has not completed her family, who is either pregnant or would like to become pregnant later, you would not like to use radioiodine. So you would prefer surgery. If there's any chance of any nodularity, possible malignancy, you would definitely not like to use radioiodine. It's not just that you would miss the diagnosis and you would miss curing the cancer, but also radioactive iodine is expected or is supposed to worsen or cause progression of a thyroid cancer, because you've the small amount of radioiodine that you use, usually 5 millicurie, that ablates the normal thyroid tissue. It does not ablate the thyroid cancer. And so the remnant thyroid cancer would progress much faster, because after radioiodine ablation, there is the TSH would increase and there's TSH stimulation. So in your patient, because of the relatively large size of goiter, exophthalmos, you would prefer surgery. And then why exophthalmos or eye signs ophthalmopathy comes into consideration? Patients who have progressive ophthalmopathy, the treatment choice is the total thyroidectomy, not even subtotal. So, and the final thing that I would like to discuss, I can see Dr. Kanagvel is getting impatient. We have taken too much time. Is the choice of surgery. Which procedure would you prefer? A subtotal thyroidectomy or a total thyroidectomy in a patient with Graves' disease?
Total thyroidectomy.
Okay. Would subtotal be an option at all, or it is not a consideration at all?
Maybe a relapse of symptoms due to subtotal thyroidectomy, due to remnant tissues. So,
okay. So again, just to cut short the discussion in interest of time, I think it is not correct to say that subtotal is not at all acceptable. Yes, and we can discuss the pros and cons. If a specialist surgeon is operating, well trained and experienced in doing total thyroidectomy safely, total thyroidectomy is indeed the treatment or procedure of choice. But if the surgeon who's operating is not very proficient with total thyroidectomy, has not demonstrated safety of total thyroidectomy, then perhaps it is better to do a total thyroidectomy. Of course, there is a slightly greater chance of relapse, recurrence over a long period, but the probability of permanent hypoparathyroidism, permanent recurrent nerve palsy, that is lower with subtotal thyroidectomy. I think we have run out of time, but I think it's a good case to discuss. We have number of issues which can be discussed further, but it's a good presentation, Dr. Kanagraj. Any other questions any of the co-panelists would like to ask? Dr. Kanagraj, you're muted.
I think we can move on. He has answered many of the questions. And
Sir Kanavil, sir, you are muted, sir.
Swagata ma'am and Smriti ma'am, do you have any questions?
Yeah, no, I already said he has presented well. So let's move on to the second case.
Okay. Any other faculty, Khanna sir, Jailal sir, senior faculty, Srinivas sir, Rajiv Sakai sir, anyone want to add some comments, sir, before we move on to the next case?
Yeah, I would like to ask one question. This is a very basic question. Say, how do you prescribe a antithyroid drug in the first setting? Would you like to go with a small dose and increase the dose, or would you like to straight away go for higher dose and then come down?
Straight away go for higher dose, then tighter the dose, sir.
So what is the frequency?
Sir?
Frequency.
After the starting the dose, after 6 to 8 weeks after the starting the treatment, we have to look for biochemical values, sir, TSH and T3, T4. And
sorry, I will interrupt you. So how frequently you will do biochemical test after starting antithyroid drug?
Initially 6 to 8 weeks after starting the treatment.
No, the first thing you do is a clinical adjustment. You don't do repeatedly. So the titering is done initially mainly with pulse rate and improvement of symptom. That should be your answer, not straightway biochemical.
Okay.
Okay.
Any other inputs from other faculty, please?
He has done well, sir. He has answered almost all the questions and satisfied Professor Gaurav Agarwal. Well trained Kanagaraj, Kanagaran, sir.
Thank you, sir.
Kanagaraj, only thing you open up and be bold, Kanagaraj.
Okay.
You are answering everything, but be bold. And as Pankaj Modi sir said, you should commit in an order.
Okay.
Okay. All right. Well done. Keep it up. Good luck. All the best for your exam.
Thank you, sir.
Kanagraj, do you have any questions or doubts to be clarified with the senior faculty here? Dr. Kanagraj?
Which book you referred, Pa?
Sir, Randolph's.
Which book you referred so that the repeat for thyrotoxicosis? Yeah.
So if I have a question, Dr. Kanagraj, I would have asked, what is difference between total thyroidectomy, subtotal and near thyroidectomy?
Total thyroidectomy is removal of the entire glands, and near total thyroidectomy is keep the 1 gram of gland along the parathyroid and the recurrent laryngeal nerve.
So that is a pitfall. There is nothing like a gram or anything. Near total means you try to remove all thyroid except some part along with parathyroid you preserve. And subtotal, as sir has said, its own way. So ideally, it should be either total or near total. The word is. Okay. Thank you.
Okay. Thank you.
Any questions from you, Kanagraj, to the faculty? Any doubts you have? Any clarification you want to do? Okay. Any other faculty would like to ask something, or can we call this case a close? I think we can allow this graves for another 1 hour. I think we have enough discussions pending. I'm sure for the want of saving time, I would like to thank Dr. Kanagraj, Dr. Karnakaran sir, and the entire Madurai Medical College team for giving this excellent case for discussion. And I'm sure Kanagraj is also, as like all of us, we have also learned a lot of things from Professor Gaurav and all the senior faculty here. So I thank Kanagraj sir on behalf of all the faculty and the students who are in the Facebook as well as in the YouTube. Now we move on to the next case. Gaurav sir, I would still be happy if you can stay for a case of portal hypertension. I'm not sure if I'm right in asking you to stay back, but feel free to leave if you have other commitments, sir.
Well,
thank you so much for joining today.
If I may be allowed, I like to leave because that bit of extra learning, I perhaps would not use that.
I understand, sir. On behalf of all of us, we thank you once again for joining. And I'm sure I would seek your time and permission to join us as a faculty whenever we have a thyroid or endocrine breast case also. So with that, we thank you for joining us today. And with your permission, we move on to the next case, sir.
Thank you so much for the invitation. I look forward to connecting again. Thank you.
Thank you, sir. Thank you. Good night, sir. Now, can I request Dr. Kaustubh from BJ Medical College? Kaustubh Shah is from BJ Medical College, Civil Hospital, Ahmedabad. He is the president from Professor Modi sir's unit, and he's been waiting patiently for the last 2 weeks for his turn to present in this forum. Kaustubh, please introduce yourself and start your presentation. I would request Madam Smriti and Madam Swakata and other faculty to take over the discussions, please. Dr. Kaustubh, over to you. Please share your screen and start your presentation.
Thank you, sir. I am sharing screen right now. Good evening, everyone. I am presenting a case on portal hypertension. This has been done under the guidance of Dr. PR Modi sir, Pankaj Modi sir, who is head of unit of our medical college, and then Dr. Maulik Mehta sir, who is my PG teacher, Dr. Hardik Bhatt sir, and Dr. Prujar Parekh sir. Moving on, I would like to have a case presentation on a case of portal hypertension, starting with the chief complaints. Patient is 8-year-old male child residing in Ahmedabad, belonging to lower class, presented to OPD with complaint of recurrent episodes of hematemesis since past 4 years. Patient was relatively asymptomatic 4 years ago when he developed one episode of hematemesis, which was bright red in color, profuse, painless, not mixed with food particle, and did not proceed with nausea. Patient had 3 to 4 such episodes within 30 minutes. Patient had to be admitted and blood transfusion by 3 units of PRC had to be done, following which an upper GI scopy was done. Then patient had similar episode 2 years ago and also one 6 months ago, for which patient was again admitted and required blood transfusion, and which was again followed each of the time by upper GI scopy. It was associated with melena for 2 to 3 days after having episode of hematemesis. There is no history of jaundice, abdominal pain, or abdominal distension. There is no complaint of any cognitive deficits or poor school functioning. Past history, there is no significant past history. Birth history, patient was delivered via normal vaginal delivery in a hospital in Ahmedabad with no history of any birth-related complication. Patient is immunized till date. Personal history, there is no history of any addiction. Patient is vegetarian by diet with unaltered appetite and sleep pattern and unaltered bowel or bladder habits. There is no significant family history in this patient. Sir, should I move on to examination?
Please wait, Dr. Kaustubh. We have Madam Smriti and Madam Swagata here, and also the other faculty. Let them ask you any questions if they have. Madam, over to you, please.
As per your history, this patient, what will be your diagnosis just as per history?
Ma'am, patient has only episodes of hematemesis, which is profuse in nature and painless, without any mixing of food particle. I would consider it to be variceal hemorrhage from esophagus.
Now, you said it is melena. What is the definition of melena?
Ma'am, any black tarry stool, patient presenting with stool which is black and tarry in nature is said to be
black and tarry and
foul smelling.
So, did this melena was a black, tarry, and foul smelling?
Yes, ma'am. It was black, tarry, and foul smelling stool.
Okay. So, as per you, the patient had only hematemesis. So, most probably varicose bleed.
Yes, ma'am.
Okay. Did the how did you rule out the infection in this patient?
Ma'am, there was no episode of fever and no episode of abdominal pain.
Okay.
And no episode of diarrhea.
No episode of diarrhea. Yeah. And there is no poor schooling functioning. Okay.
Can I ask
what were the chief complaints of this patient?
Sir, the chief complaint, patient had presented for routine follow-up for patient having history of recurrent episodes of hematemesis since past 4 years.
Where is the slide for the chief complaints? Can we see that?
Sir, this in first slide, in first paragraph, I have mentioned that patient has presented to OPD with complaint of recurrent episodes of hematemesis since past 4 years, sir.
Can I ask one question?
Yes, sir.
Is there any history of umbilical sepsis?
Sir, there is no history of umbilical sepsis. There is, as I have mentioned in birth history, sir, there was no birth-related complication in this patient.
I'm specifically asking, is there any umbilical sepsis?
No. Yes, sir. No episode of any fever or purulent discharge from the umbilical side at birth, sir.
Yes.
Go again to the first slide, please.
Yes, sir.
You are saying 8-year-old male child. Is that the correct thing you should tell? 8-year-old male child.
Sir, 8 years.
Yeah, it cannot be old, na?
Yes.
You know, old is here concern about that patient is really elderly patient, na? But here you should not say the old. It's an 8-year male child, which is there you can say. Na?
Yes.
Now, his history starts from 4 years?
Yes, sir.
Okay. At that time, what was the age of this child? 4 years?
4 years, sir.
Okay. Now, what happened at that time when he had the episode of the hematemesis? Was he hospitalized at that time?
Yes,
or...
sir. Yes, sir. Patient was hospitalized immediately in a nearby hospital, where immediately patient was transfused 3 packed red blood cells, sir. And then the following day, patient was had undergone an upper GI scopy, sir.
Now, if this patient have presented only with the hematemesis, so still you will like to keep the first diagnosis of the varicose hemorrhage?
Yes, sir. If patient would have presented with bright red color hematemesis, which is profuse and painless and not mixed with food particle, then, sir, I would keep varicose hemorrhage as my first diagnosis.
So in the varicose hemorrhage, you get the bright red color blood in the vomitus?
Yes, sir.
That is bright red color, isn't it?
Sir, unaltered red color, sir, which is venous with. So
how do you differentiate whether it is a hemoptysis or it is a hematemesis?
Sir, hemoptysis will be preceded with coughing episode, sir, with complaint of breathlessness, sir. And will be mixed with frothy discharge, sir, of sir.
What is the color of the blood in the hemoptysis?
Sir, bright red color, sir.
The same is in the hematemesis also?
Sir, in hematemesis, it will be darker in color in relation to hemoptysis because varicose bleed mostly is venous in nature, sir.
Any other reason that why the color changes?
Sir, it might be altered due to gastric content, sir, with acid hematin formation.
Yes. So because of acid hematin, there will be change in the color. Will be there. What is the difference in the amount of the blood which is there in the hemoptysis and hematemesis?
Sir, sir, in hemoptysis, it is 30 to 50 ml, sir. In in hematemesis, it is profuse, sir. Could be 100 to 200 ml.
And just say that there's a small amount usually in the hemoptysis, but a large amount in the hematemesis may be there. Okay. Go to the next slide now.
Yes.
So how many times he had bled in the last 4 years?
So 3 times.
How many times he was admitted?
The patient had bled 3 times, and all 3 times patient was admitted, and all 3 times patient had required blood transfusion.
Okay. And as it was asked that this patient gave the history of umbilical sepsis?
No, sir. Patient did not give history of any birth-related complication.
The parents must have told that.
Yes, sir. Father.
There was no history of umbilical sepsis was there.
No, sir.
No. Can you tell what are the other, apart from the umbilical sepsis, what other inflammatory conditions can cause the portal hypertension?
Sir, schistosomial infection can cause portal hypertension, sir. Okay. With sir, hepatitis C will ultimately cause portal hypertension, sir.
Okay. Any other case of any acute abdomen which can cause the portal hypertension?
Sir, portal vein thrombosis can cause.
Because of which inflammation or infection it can cause the?
Sir, appendicitis or infected hem.
The simple appendicitis can cause the portal hypertension. The pancreatitis can cause the portal hypertension.
Or infected
can cause the portal hypertension. So all these things can be. What is the sinistral type of the portal hypertension? The sinistral type of the portal hypertension is that it is of the left-sided portal hypertension. Okay, that is called a left-sided portal hypertension. Like a patient has got any pancreatic problem is there, because of that there is splenic vein thrombosis is there, pancreatic tumor causing the splenic vein thrombosis. All these things can cause the
sinistral
type of hypertension. Right. Go to the next slide. Patient was delivered, normal vaginal delivery was there. Okay. Why the family history?
Sir,
in the family history, you have written no significant past history.
Sir, patient, we have to rule out congenital, we have to rule out genetic disorders like leukemia or platelet disorders, which might have caused portal vein thrombosis, ultimately leading to portal hypertension, sir. Polycythemia vera.
There are certain familial diseases which are there, which can be in the families leading to the portal hypertension.
And
okay.
Alpha-1 antitrypsin deficiency also, sir.
Okay, go to the examination now.
On examination, patient was examined in a well-lit room in supine position with proper exposure and informed consent. On general examination, patient is conscious, oriented to time, place, and person, and comfortable. Patient is afebrile. Pulse rate is 92 per minute. Blood pressure is 108/72 millimeters of mercury. Pallor is present. There is no icterus, cyanosis, clubbing, lymphadenopathy, or no peripheral edema. There is no stigmata of liver disease, liver failure. On systemic examination, in abdominal examination or inspection, there is a visible fullness in left hypochondrium and left lumbar region. Umbilicus is centrally situated and inverted. There is no scar, visible swelling, or discharging sinus. No visible dilated or tortuous veins are seen. On palpation, surface temperature is normal, and there is a 8 into 6 centimeter non-tender lump extending from left hypochondrium region to left lumbar region, which is firm in consistency and having smooth surface, and margins are well defined inferiorly, medially, and laterally. Superior margin not palpable, and swelling moves craniocaudally with respiration. Fingers cannot be insinuated between costal margin and the lump. There is a palpable notch in the lump. Rest of the abdomen is soft. There is no tenderness and no hepatomegaly. Bilateral testes are normal in shape and size. On percussion, there is dull note over the lump, which is in continuation with splenic dullness. There is no shifting dullness. Liver span is 10 centimeter at mid-clavicular line. On auscultation, normal peristalsis could be heard. On per-rectal examination, there is no abnormality detected. Respiratory system bilateral air entry is normal. In CVS examination, there is S1 and S2. Normal heart sounds are heard with no murmur, and CNS examination is normal.
What do you mean by the stigmata of the liver failure? No stigmata of liver failure.
Patient had no signs of alopecia. No, there was no icterus. There was no palmar erythema, no spider angiomata, no dilated tortuous veins over the umbilical site in the anterior abdomen. There were bilateral testis was normal. There was no gynecomastia.
Something else?
While there was no visible or palpable parotid swelling.
If this patient would have the veins over the anterior abdominal wall and you want to test that what is the direction of the flow to differentiate between a portal obstruction and the IVC obstruction. So how do you examine the veins?
Sir, if the veins are in radiating direction and radiating towards the in a radial manner towards the liver, then it is supposed to be from portal hypertension, and there will be flow which is hepatopetal towards the liver, sir, and away from the umbilicus. And if there is an inferior vena cava obstruction, the flow will be in a single direction, moving from below upwards, sir. And if there is superior vena cava obstruction, the veins will fill from upwards below, sir.
How do you have sent, you have written pallor present. So what was the grade of pallor?
The pallor was present in lower palpebra only, ma'am.
So mild pallor, moderate.
Mild pallor.
Also, coming back to the veins which are there, where you will examine the vein? That was my question.
Sir, at the umbilicus, sir, we will first empty the vein, sir, in the direction.
But at the umbilicus, you can get both. You have to look for the direction of the veins.
Yes, sir.
In which direction it is flowing, the blood is flowing.
Yes, sir.
So for that, will you examine it above the umbilicus or below the umbilicus?
Sir, above the umbilicus, sir.
If you examine above the umbilicus, the direction will be the same in both cases. In the portal obstruction also, because it is away from the umbilicus. And in IVC obstruction also, it will be again from below up.
Below upwards, sir.
So the direction will be the same. So you have to always examine it below the umbilicus. Okay, never examine it in above the umbilicus, examine it below the umbilicus, and then the direction will be different.
Yes.
Okay. What are the other ways to differentiate whether it is the IVC obstruction or whether it is the portal obstruction?
Sir, in IVC obstruction, there will be congestive hepatomegaly. In portal vein obstruction or portal.
Why there will be congestive hepatomegaly in IVC obstruction?
Sir,
talking about cherry?
Yes, sir. Supra, if there is post-hepatic IVC obstruction, sir.
Yeah, if it is
But
suprahepatic is there, then you will get the congestive. But if it is infrahepatic variety,
sir, there will be pedal edema and signs pertaining to deep venous thrombosis might be present, sir. And
there can be bilateral edema.
Bilateral pedal edema will be present, sir, in IVC obstruction.
In both it will be there. The patient who is having the portal hypertension, because of the hypoalbuminemia, you will get the bilateral pedal edema. And also in the case of the IVC obstruction, you will get. So you have to look at the back of the patient. What you will find in the back of the patient?
Sir, presacral edema will be present in patient with IVC obstruction, sir.
No, you look at the back of the patient to see for the prominent veins there. If you find the prominent veins there on the back of the patient, then it is likely to be the IVC obstruction. If they are not there, it's more likely to be the portal one. Okay?
Yes.
So apart from the direction of the flow which is there, second is looking at the back of the patient to see do you have the veins there or not.
Yes.
Okay. Can you go to the next slide?
Yes, sir.
Go to the next slide. This is visible for us. Next slide.
Yes.
There is no free fluid in the abdomen.
No free fluid in the abdomen, sir. No, I have done shifting dullness and puddle sign in this patient, which was negative.
Do you expect in this patient the free fluid in the abdomen?
Yes, sir. Patient is an 8-year-old male child, and I suspect portal hypertension in this patient. So I expected free fluid, sir.
What is the cause of the portal hypertension in a child usually?
Sir, usually it is extrahepatic portal venous obstruction or congenital hepatic fibrosis or Wilson's disease.
So if it is the extrahepatic type of the portal hypertension, do you think the patient will have the fluid in the abdomen?
Yes, sir. Ascites can be due to portal hypertension as well, sir. Less likely in comparison to hepatic cause, but
because the liver will be normal here, isn't it?
Liver would be normal. Yes, sir.
Okay, so there is very less chance of having the ascites. Okay, if it is a hepatic cause is there, definitely you will, or if it is a post-hepatic cause is there, definitely you will have a lot of the ascites. Go to the next slide, please.
Yes.
Now, on auscultation, what are the various sounds you can hear in a patient with a portal hypertension?
First of all, sir, normal peristalsis, and secondly, if there are dilated veins present over the abdomen, then a venous hum can also be heard over the umbilicus, sir.
Any other sound you can hear on auscultation? If the patient has got the perisplenitis is there, which is in a good number of the cases, you can find the perisplenitis. So what you can hear there on auscultation?
The crepitus, sir.
Yeah, it will not. It's not the crepitus. It's called the splenic rub. And just like in a pleuritis, you hear the pleural rub. Similarly, here in the perisplenitis, you can hear the splenic rub may be heard. Okay. Go to the next slide.
Yes. Sir,
tell about that.
On summary, there is an 8-year-old male 8-year male child with complaint of recurrent episodes of profuse painless hematemesis since past 4 years, presenting to OPD for routine follow-up upper gastrointestinal with failure and grade 2 splenomegaly.
What is this painless hematemesis?
Sir, to rule it out from Boerhaave syndrome, patient does not have any episode of pain while having hematemesis, sir. And there is no history of abdominal pain with chronically as well to rule out peptic ulcer disease, sir.
Painless is not used for the hematemesis, isn't it? Painless hematuria is okay, but painless hematemesis is usually this term is not used here. Okay. And just say there's a profuse hematemesis is there.
Yes.
Along with melena. No?
Yes.
Right. What is this grade 2 splenomegaly?
So by Hackett's grading, sir, the spleen was present, which was spleen was palpable from the costal margin to the just behind the lateral to the mid-clavicular line, sir, left mid-clavicular line. So coming to, sir, grade 2 splenomegaly by Hackett's grading, sir.
If you just feel the spleen, how much is the enlargement is there?
Sir, 2 to 3 times. Sir, 2 to 3 times the normal size, sir.
Okay. Then only it will become palpable.
Palpable.
Right. Okay. So, what is your diagnosis?
Sir, my clinical diagnosis would be portal hypertension with splenomegaly with hematemesis. Cause could be, sir, prehepatic, hepatic or post-hepatic. In prehepatic cause, sir, I would like to keep extrahepatic portal venous obstruction as my first provisional diagnosis, given patient's age and presentation at age of 4 years, sir. And second, I would like to keep in hepatic cause in in pre-sinusoidal cause, sir, congenital hepatic fibrosis. And in hepatic cause, I would like to keep, sir, or sinusoidal cause, Wilson's disease, which might be compensated right now.
What are the post-sinusoidal causes?
Sir, post-sinusoidal causes would be veno-occlusive disease or Budd-Chiari syndrome, sir. And post-hepatic cause would be IVC obstruction.
What are the various types of the Budd-Chiari syndrome and what are the various presentations?
So Budd-Chiari syndrome can be acute or chronic, sir. In acute Budd-Chiari syndrome, sir, there is abdominal distension with abdominal pain, and patient may present with episode of hematemesis. Sir, in chronic Budd-Chiari syndrome, there will be history of repeated paracentesis for refractory ascites.
According to the type of the involvement, what are the various types of Budd-Chiari? Okay, there can be only involvement of the hepatic veins.
Yes.
Or there can be involvement of the IVC only, or there can be both involvement may be there. Both the IVC as well as the hepatic veins are involved. And the presentation in all the three will be different.
Sir.
So you want to give any differential diagnosis here or you just want to give one diagnosis?
Sir, I would like to give hepatic type of portal venous, hepatic type of Budd-Chiari syndrome in this hepatic vein thrombosis.
No, apart from the portal hypertension, what are the two cardinal features of portal hypertension?
Sir, hematemesis and ascites. And splenomegaly.
Hematemesis and the splenomegaly are the two cardinal features of the portal hypertension. So tell what are the other causes of the bleeding along with the splenomegaly?
Sir, patient having tropical splenomegaly with chronic NSAID abuse. Patient may have schistosomial infection or bilharziasis.
Can it be leukemia?
Yes, sir. In acute myeloid leukemia also due to platelet, due to raised INR, sir, and decreased platelet count, sir. Thrombocytopenia in AML can also lead to hematemesis with massive splenomegaly.
So if you suspect the patient is having the leukemia as the cause for that, will you go back to your examination and examine certain other things? So what are those things you are going to examine now?
Sir, I would like to look at the lymph nodes over lymphadenopathy in cervical region, in axillary region, and hepatomegaly would be there, sir.
Now, what other features you will get in a patient of a leukemia which has the bleeding?
Sir, there will be pallor might be present. Patient will be asthenic.
That you already examined. I asked you that what other things you will examine in such a patient where you are thinking now the patient has got the leukemia. Will you examine the skin of the patient to see for something?
So,
you can get the purpuric patches over the skin. Will you examine the oral cavity of this patient for something?
So we would look to gum hypertrophy and
look for the gum hypertrophy. Will you check for any tenderness especially?
Sir, bone.
You check for the bony tenderness, no? Sternal tenderness may be there. Okay, you check for that. All these things you will again examine if you are keeping these in your mind.
Yes.
Okay. Now tell clinically how can you differentiate whether it is a pre-hepatic or a hepatic or the post-hepatic type of the portal hypertension?
Sir, in post-hepatic hypertension, sir, there will be hematemesis with varices with splenomegaly. On if it is a hepatic cause, then there will be.
What will be the age group of the patient?
Sir, age group of the patient could be, sir, young male patient in case of extrahepatic portal venous obstruction. If we are suspecting non-cirrhotic portal fibrosis, then patient's age would be on first presentation would be around 20 to 30 years of age, or maximum reaching up to 40-45 years. And in hepatic cause, sir, we would like to elicit history of alcohol abuse or check the BMI of the patient to look for signs of non-alcoholic steatohepatitis, and patient will also have history of jaundice, and on examination may have icterus with abdominal distension, a history of abdominal distension and free fluid in abdominal cavity. In pertaining to ascites, there will be generalized edema or anasarca in case of hepatic cause.
What is the post-hepatic variety? Apart from the Budd cherry, what are the other causes for the post-hepatic variety?
Sir, right heart failure, sir. Or sir, right heart failure, sir. Severe tricuspid regurgitation. Sir,
Constrictive pericarditis.
Pericarditis, constrictive pericarditis, and
So, in this patient, what do you think? What is the cause of portal hypertension? If it is extrahepatic cause is there, what is the cause for the extrahepatic in this patient?
sir, in this patient, extrahepatic portal venous obstruction.
What are the causes of the extrahepatic portal venous obstruction?
Sir, 60% of the patients are idiopathic, sir. In 20% of the patients, there is previous history of umbilical sepsis, and there will be history of recurrent episodes of septicemia in patients with extrahepatic portal venous obstruction, sir.
I'm asking you, what are the causes of the extrahepatic variety of the portal? One, you said it can be idiopathic. Second,
Sir,
you said it's umbilical sepsis is there.
Portal vein thrombosis, sir, due to.
I told you all inflammatory causes, you know, patient having the appendicitis, pancreatitis, and all that can cause. There's a portal cavernoma formation is there. Most of the time, it is the idiopathic variety. Okay, then there may be some tumor which may be pressing, especially the pancreatic tumor which are there. That may be causing the extrahepatic type of the portal hypertension. Okay. So how you are going to investigate this patient?
So first, I would like to go for a complete blood count or liver function tests, sir, including all liver enzymes and total bilirubin with serum protein, sir.
First, you have to make your diagnosis, is it?
Yes, sir.
You have to establish your diagnosis. So first, do the investigations, which will be helpful in the making the diagnosis.
Sir, I would like to go for ultrasonography first.
Just the ultrasonography or something else combined with that?
With sir, upper GI endoscopy, sir.
No. In the ultrasound, will you combine something else?
Sir, portal vein Doppler.
Along with ultrasound?
Sir, portal venous Doppler, sir.
You will do a duplex scan.
Duplex scan.
Okay, so you will do the ultrasound and also you will do the Doppler GI. Now, what are the things you will see in the ultrasound in this patient?
Sir, there we would look for the size and texture of liver. We would look for portal vein diameter, portal vein velocity in duplex scan, and splenic vein diameter and velocity, sir. And formation of collaterals or cavernoma formation. We would like to look for splenomegaly, the size of spleen and the texture of spleen, and we would also like to look for free fluid in the abdominal cavity.
What is cavernoma?
Ma'am, it is a gross dilatation of the vein along with and there are multiple septations inside due to endothelial proliferation.
Along which vein?
Along with endothelial proliferation
in sonography, along which vein will you find the cavernomas?
Ma'am, usually along portal vein.
And splenic vein.
And splenic vein.
Carry.
Define a portal hypertension.
Sorry, sir.
How do you define portal hypertension?
Portal hypertension is defined by venous pressure of more than 5 millimeters of mercury, sir.
5 millimeters of mercury in the portal?
Yes, sir. Portal venous pressures, which we can measure by hepatic venous portal gradient pressure, sir.
You're talking of the gradient or you're talking of the pressure in the portal vein?
Sir, pressure in the
What
portal
is the
vein,
normal portal pressure?
sir, less than 5 millimeters of mercury, sir.
Are you sure about that?
Then
Yes.
what about 5 to 10 mm? How will you label those?
5 to 10 will be portal hypertension. What?
Again, define portal hypertension.
Portal venous pressure more than 5 millimeters of mercury is considered to be portal hypertension.
It is more than 10 mm.
Okay. The normal portal pressure is around 8 to 12 millimeter mercury.
Now above it, it is.
Yeah. Now, what are the things you will see in the liver in case of the patient having the cirrhotic liver?
Sir, patient in ultrasonography will have either shrunken liver or hepatomegaly, depending upon the cause. If it is macronodular, nodules will be visible. The size of the nodules, if they are more than 5 millimeter in size, we will consider it to be macronodular. And the texture, if it is altered, then it suggests a chronic liver parenchymal disease, sir.
Now, what are the various pressure studies you can carry out in a patient with portal hypertension? What are the various types of the pressure studies you can carry out in the patient with portal hypertension?
Sir, we can go transjugular and measure the hepatic hepatic vein wedge pressure and hepatic vein
pressure. Yeah, right.
and the difference of it can also be calculated. Hepatic venous pressure, hepatic venous wedge pressure, and difference of it, sir, hepatic venous gradient pressure.
You know what is hepatic occluded portal pressure and what is the splanking occluded portal pressure?
Sir, we introduce the catheter up to the hepatic vein and just at the part where it joins the hepatic sinusoids, we occlude it with balloon and then measure the pressure, which gives us the hepatic occluded venous pressure, sir. And in splanchnic, sir, I haven't read, sir, splanchnic.
Usually it is done at the time of the operation when you are carrying out. You can put a clamp there and measure the pressure on the either side, and you want to see whether it is a hepatopetal flow is there or whether it is a hepatofugal flow is there.
Yes.
Okay. Okay. So after you have done the color Doppler, will you see the collaterals in the when you are doing the ultrasound?
Yes, sir. We will find collaterals in ultrasound, sir. Maybe
what are the places where you will find the collaterals?
Sir, periportal, perisplenic, peripancreatic. In mesenteric region, sir.
Can you tell what are the normal sites of the porta systemic anastomosis?
So normal sites at gastroesophageal junction between cardinal veins and the short gastric veins, sir, and azygous system. Then between superior, then in the submucosal plexus of rectum, in between superior rectal veins and the middle and inferior rectal veins, sir. In anterior abdominal wall, sir, in between umbilical veins and direct veins from portal vein towards umbilicus, sir. And above, sir, above at the bare area of the liver, there is between phrenic small veins of tributaries of phrenic vein and the portal tributaries, sir.
No, in this patient, did you do the rectal examination?
Yes, sir.
For an-
Yes, sir. We did per rectal. I did per rectal examination, sir.
For
which
what?
was normal, sir. For looking for hemorrhoids, sir. Internal hemorrhoids.
So your intention was looking at the internal hemorrhoids in a patient who has got the portal hypertension?
Yes, sir. To look for internal hemorrhoids or if there is any thrombosed or infected hemorrhoids, sir.
So one site you did not tell about the porta systemic, and that is the site why you wanted to see further on the DRE and proctoscopy to see for that. What is that site?
Sir, between superior rectal vein and the middle and inferior rectal vein, sir.
So when you're doing the proctoscopy, you will see further?
Sir, in internal rectal varices, sir.
Rectal varices. So your purpose for a patient in a patient of the portal hypertension, you want to see for the rectal varices there. Now, how do you differentiate between the rectal varices and the hemorrhoids?
Sir, hemorrhoids would be with bluish discoloration, submucosal, and located specifically at 3, 7, and 11 o'clock position, sir. Maybe and having a pedicle, sir.
What is the color of the hemorrhoids?
Sir, bluish discoloration.
And varices?
Sir, ma'am, varices would be dark red in color.
Is the hemorrhoid arterial or venous in origin?
So,
there is a procedure where you ligate all the arteries, Doppler guided arterial ligation, is it?
Yes, sir. The hemorrhoids would be arterial in origin and rectal varices.
So they will, so they will look more reddish rather than the bluish one, while the rectal varices will look more bluish. And if you pass a proctoscope, what finding will be there?
Sir,
you can compress the rectal varices, but the hemorrhoids will protrude inside the lumen of the proctoscope. Okay, by these ways you can differentiate whether it is a hemorrhoid or whether it is a rectal varices. Okay, after the color duplex you have done, what next you want to do? Any other investigation to make the diagnosis?
Sir, I would like to go for an upper J endoscopy in this patient, sir.
Okay, and what you want to see there?
Sir, esophageal varices and gastric varices if present.
Now tell, why does the, which varices they bleed usually?
Sir,
like the whole of the esophagus is filled up with the varices. Which varices will bleed? The lower part or the upper part?
Sir, lower part within 5 centimeter of G junction, sir.
Why do they bleed? Why not the upper part?
Sir, there is more pressure gradient across G junction and lower esophagus.
Anything else? Anything else? Any anatomical reason for that?
Sir, it is
in the lower esophagus, they are more superficial toward the lumen, while in the upper esophagus, they are relatively more deep. And the number of the varices which are there, they are much more in the lower one as compared to the upper one. And third, you said there's a change in the pressure which is there. Because of all these reasons, that the varices which are at the lower end, they bleed much more as compared to the Upper one. You know how to grade the varices on endoscopy?
No, sir.
Okay, depends upon, there are several gradings which are there. Whether you can just see the varices there, whether they are seen more on the inspiration, whether it is occupying how much of the lumen of that, whether their varices on varices are there. There are several classification of the, so you must read that what are the various 1 or 2 classifications for grading of the varices. After the endoscopy, what next you will do? Anything else you want to do?
With ultrasonography and upper GI endoscopy, sir, diagnosis is in this patient, it is clearly extrahepatic portal venous obstruction, sir. I would like to go for a hemogram to look for if there is any signs of hypersplenism and LFT to rule out if there is any changes in the liver function, sir. Which may
whenever you are making a diagnosis of portal hypertension, one of the very important thing you have to tell about the some grading is there. What is that grading? You have to always tell because your treatment will depend upon that. So which grading is there?
Child Turcotte grading, sir. Scoring system, sir.
Yeah. Modification or the child's one?
Sir, modified child Turcotte score, sir.
What is the modification? The name of the modifier? PUX, no?
Yes, sir.
PUX modification of the child's criteria. And what are the things which are included in that?
Sir, serum bilirubin, serum albumin, prothrombin time, ascites, and encephalopathy.
So can you just clinically, you can say that what is the child's criteria in your patient clinically without knowing any investigations?
Yes, sir. We can say, sir, if patient is having generalized pedal edema, generalized anasarca, his serum albumin level are likely to be less than 2.5. If patient is having deep jaundice, his serum bilirubin level is likely to be more than 3, sir. And if patient is having is in coma, or there is only clinical grading of hepatic encephalopathy, sir. So we can score according to the if it is grade 1 or 2, then the score will be 2, and if it is grade 3 or 4, then score will be 3 for child Turcotte scoring.
So where your patient is going to fit, in which grade?
Sir, there are the score would be less than 6, sir. So 5 or 6, sir. So patient will find himself in class A of
child. So child's grade A, it will be there in your patient.
Yes.
Okay.
The patient is having hematemesis, you have put an endoscope and you have diagnosed that there are varices. Now, what do you want?
Ma'am, either we will go for sclerotherapy or bending, ma'am.
Which one first?
Ma'am, if our vision is occluded and bend could not be applied at that position, we would go for sclerotherapy. In sclerotherapy also, if intravaricial injection is not possible, we will go for variceal injection. And if they are visible, fairly visible, then we would go for bending, preferred over sclerotherapy.
Right.
So will you prefer the bending or will you prefer the sclerotherapy?
Sir, preferable is bending, sir.
The reason for that? Why not the sclerotherapy?
Sir, sclerotherapy, sir, if we fail while doing sclerotherapy and we will have to put tamponade, we have already, there might be chances of esophageal injury due to previous sclerosant injection and it may result in esophageal necrosis at the site of injection.
So that may be acute problem, and later on, if you have to operate these patients, and if you do any, especially if like you have to do any disconnection procedures, that area may be all fibrosed because of sclerotherapy. And sclerotherapy has got the systemic complications also. You know what are the systemic complications of the sclerotherapy?
Sir, there can be hypertensive urgency on and anaphylactic reactions.
Anaphylactic reaction is there. If this sclerosant goes into the circulation, it has even caused the blindness, or there may be the digital gangrenes may be there. So all those complications can occur if the sclerosant goes into the systemic circulation. Now tell, in a case of the portal hypertension, what are the things you want to treat? What are the various things you are going to treat?
Sir, recurrence of hemorrhage, recurrence of
bleed which is there.
Yes.
Okay, so upper GI bleed is there, that you are going to treat. What other things you are going to treat? What is your aim for the treatment of the portal hypertension?
Sir, if there is hypersplenism, I would like to go for
hypersplenism. Yes. Third,
sir, if there is ascites.
Fourth, encephalopathy. Okay, so these are the main 4 things you are going to treat. Now tell how you are going to treat the hematemesis. But that will all be going. It's going to take a long time. So already, Dr. Kanagal, we should continue, or Dr. Kanagal?
Sir, I would say we can finish 2 more issues of portal hypertension, sir. Maybe in another 5-10 minutes. Is that okay, sir?
Okay.
Please go ahead, sir.
Yeah. So tell, what are the various scenarios for the bleed?
Sir, if patient is presented to us with an acute episode of hemorrhage, then endoscope, first of all, after stabilization of the patient, we will go for endoscopic therapy, sclerotherapy or banding. If there is persistent bleeding still, then we would like to, if immediate surgical, if TIPS procedure cannot be done in our setting, we would like to go for tamponade procedure by Singh-Staken Blackmore tube placement. And after 24 hours, there can be 2 options. If there is no portal vein obstruction, I would like to go for TIPS procedure. And if there is persistent bleeding even after TIPS procedure, we might have to go for emergency non-selective shunting procedure or Sigvara devascularization procedure.
Madam, you can take over, Madam, you want to ask any questions?
If
So now, what is the? I think he had already told about splenectomy. I think more or less covered. You have, sir, covered everything.
Dr. Kostov, with so much of discussion on portal hypertension, what do you think is the one-stop surgery which will cure portal hypertension?
Liver, if it is hepatic cause, liver transplantation, sir. Fine.
So that's the one-stop surgery which will clear the portal hypertension. Here, the present guideline says as long as you have a functional residual liver, you will try with medical therapy. If there are primary parenchymal failure, or if the venous complications because of the parenchymal failure is more and more and repeatedly happening, and the patient gets into repeated sepsis because of these type of interventions which are for the parenchymal related venous complication, then they become indication for portal liver transplantation, right? So That's why now the external shunt procedures are slowly coming, like they are slowly getting out of vogue. They do a interventional shunting, internal TIPS procedure. If TIPS also is not successful, then your one-stop solution is liver transplantation, right? So you should be also be able to know and tell about the what are the 1, 2, 3, 4 indications of liver transplantation. All right.
Yes.
Right. Do you know any interventional procedure apart from TIPS for portal hypertension?
Sir, for gastric varices or gastric variceal bleeding, there is and balloon anterograde trans artery.
How do you approach the gastric fundal varices?
Sir, by renal vein, sir.
So how do you approach the renal vein?
Sir,
you should read about it. Lot of exciting things are coming up, especially even for esophageal varices, temporary balloon tamponades, so many other radiological intervention, definitive intervention, as well as the temporary intervention are coming up. I would like to have some fundamental questions. Have you heard of any tubes which can temporize esophageal variceal bleed?
Sir, Sengstaken black mold tube or Minnesota tube.
Okay, what is the fundamental difference between Sengstaken and Minnesota?
Sir, in Minnesota there are 4 channels and 2 balloons, sir. In gastric, in Sengstaken black mold tube, sir, there are 3 channels and 2 balloons, sir. The one balloon in Minnesota is for installation of cold lavage. Otherwise, there is gastric balloon and esophageal balloon in both of the tubes, and an aspiration channel with the inflation tube for both gastric and esophageal balloon in both the tubes, Minnesota as well as Sengstaken.
Other faculty, anyone to add up something? Madam?
Can a patient die because of black smoke tube?
Yes, sir.
Sudden death may be there because of black smoke tube?
Yes, sir. Esophageal rupture is a complication of.
Why does the patient die because of?
Sir, if we.
What happens?
If so, sudden vasovagal shock and the pneumomediastinum.
No, there will be direct compression will be either of the balloon if it ruptures. Okay, it may go behind the trachea and it may directly compress the trachea right at that point, and the patient can die because of the asphyxia because of that. Okay.
Do you have any preparation? Patient is taken food, or patient is taken. Patient does not have a prepared stomach. Can you do anything for before doing an emergency endoscopy?
Sir, RT insertion is controversial in cases of hematemesis, sir. To give lavage.
I'm asking a very simple question. I'm not asking you to give a lavage. Do you have any intervention in mind prior to preparation for an endoscopy? Very simple question. Use of prokinetics can be considered. Use of IV metoclopramide can be considered. Use of sublingual domperidone can be considered. All right.
Yes.
And then, is there a role for, see, when you go into the stomach, especially when you have portal congestive gastropathy, when you have diffuse gastric bleed, you will be able to see only a melanic stomach type of picture, or you are not able to see any fixed bleeding points. Is there any method to clear the areas, doubtful mucosal bleeds during endoscopy?
No idea.
Okay, so there are 2-3 options to do it. One is to primarily patient can consume plain water. So now underwater endoscopy is an accepted thing. Underwater colonoscopy is already very commonly done. So underwater endoscopy is also possible. That is very simple therapy. The second therapy is to consider foaming agents, right? Especially the aerated drink and other things. Number three, third thing is you can now you have a double lumen therapeutic endoscopes. I'm not talking about the ERCP scopes, therapeutic endoscopes, where you can gently wash with the water jet and keep proceeding with the diagnostic part. All right. So the very simple thing is IV metoclopramide in primary thing during endoscopy. So when you're asked about this question, you write pre-preparation, intra-procedural preparation, and after you do a scopy, if you are unsure of it, you can as well do a repeat endoscopy within 24 hours, provided the patient is hemodynamically unstable, hemoglobin is dropping, then you can always repeat a secondary endoscopy. All right, most of the times you don't need a big preparation for handling a esophageal varices. But then if you want to do a proper stomach procedure, you optimally need to clear or wait at least 3 to 4 hours for it to clear off. Most of the time, when there is a mere presence of blood in the stomach itself is an irritant, it clears off the content of the stomach. That is a one more added advantage. For the matter, entire colon gets cleared off when you have blood in the intestines because blood is a potential irritant.
Yes.
All right. So I think we are running more late and late. Do you have any quick clarifications from the faculty here, Kaustubh?
There are several medical treatments also. No? You can use the vasopressin, you can use the terlipressin, you can use the glypressin. All those things can be used for a patient of it having the acute bleed is there.
Do you know anything about Wilson disease? And can Wilson disease be present in this case?
Yes,
ma'am. Pediatric patient?
Yes, ma'am. Wilson's disease can present at this age and will be compensated in this, will be having compensated cirrhosis in this case, which might mimic.
Might mimic it. So what is Wilson's disease?
Due to deficiency in ceruloplasmin, there is copper deposition. There is copper deposition in the liver and eyeballs of in iris of the patient. It is mostly due to deficiency of ceruloplasmin, carrier of. It is an autosomal recessive condition, which presents first with portal hypertension and then later on develops into cirrhosis by 20 years of age, adolescent age.
Okay.
Now, sir, madam, can we call it a close, madam?
Yeah. I think so.
Thank you, faculty. Thank you, all the other faculty who are in the Zoom as well as in the YouTube. So thank you, Kaustubh. Thank you, Dr. Kanagraj. Thank you, Modi sir, and thank you, Karnakaran sir, for permitting your PG to present a case here. So with that, we call this session a close. We look forward for yet another interesting session in the coming week. So I thank all the faculty who have contributed today for this event, especially this is an anniversary event for us. So I'm sure we will be looking forward for more and more interesting activities in the coming week. So we will announce with the, we will have a discussion with the academic committee members. And I also request the faculty here to permit their PGs to present in the coming classes. And you please feel free to suggest any other faculty who will be interested in contributing, your colleagues, your seniors or your juniors who are definitely keen in contributing. We will be more than happy to have them amidst us. With that, we thank all the faculty here, students here, as well as the faculty and students in the YouTube for joining us this evening. Good night, everyone. Good night, sir. Good night, madam. Jailal sir, thank you. We are in the airport, I believe.
Yes, I am in the airport, just boarding the flight in Delhi. So thank you.
Mornings you are in working, evenings and nights you have night red-eye flights for exclusively for you, sir. Sir, when will you buy Air Force One for IMA, sir? IMA Air Force One.
If all of you are hoping it will happen, sir. So So I mean, I'm really enjoyed this class, especially Ajay Khanna sir rocked today, and the candidate we must appreciate, and he has really fairly very well. He has raised the question with very calmness, with very confident and cool. He has answered, and that is a very good sign. So thank you, both candidate and Ajay Khanna sir. It was super today.
Thank you, sir. Thank you. Khanna sir, you're in mute mode.
Thank you very much.
Thank you, sir. Thank you, sir. Jailal sir, have a safe trip.
Thank you.
Catch up and sleep in the flight, sir. Good night, sir.
Good night. Good night.